Hello there, I'm Dr. Vivian Lowe. You're on vlmd Rounds, a podcast on medical science and tools to optimize your health. Continuing on with my series on atherosclerosis, today we are going to be discussing vascular calcification. Let's go. All right, the first thing I want to say is that I am actually focused on intimal disease in the tunica intima of the blood vessel, which is the innermost area of the blood vessel closest to the lumen where the blood flows, because there's also medial disease known as Monckeberg's variant, and there we see calcification and hardening of the medial wall, the tunica media of the artery. We are not going to be discussing that. I just wanted to make that clear because sometimes people get that confused, and the processes are quite different in Monckeberg's variant versus with the intimal disease that we're going to be discussing today. Now, there are three main points that I will bring up, and one is just to talk about the general process of calcification. And then I'm going to go into just a couple of risk factors that I want to bring to your attention. And then finally, we're going to look at calcification and also risk of plaque rupture, right? That association between calcification and plaque rupture. All right, let's start with the process. So, when we used to talk about vascular calcification, we used to think of it as a passive process. There's damage in the wall of the blood vessel, and then there's fibrosis, and part of the healing process, calcium deposits accumulate. However, nowadays we know it's not a passive process, it's quite an active process. We actually have active bone formation, if you will, in the blood vessel walls, right? It's very much akin to bone formation in the long bones, for instance. And the cell types that are involved would be the pericytes in the microvessels, and also parasite-like calcifying vascular cells in the intima of the blood vessel wall. We have vascular smooth muscle cells in the tunica media, and myofibroblasts in the tunica adventitia. So those are the different cell types that can get involved here with the calcification. We've talked extensively about the formation of the atheroma, and basically it's the result of an immune response to oxidized LDL, right? I've been talking about atherosclerosis as an autoimmune disease, and we end up with this plaque formation that is chock full of macrophages, right, that have gobbled up lots of oxidized LDL, and we have a rich core of lipids and macrophages, and then there's surrounding cuff of T cells as well. Now, in the center of the plaque, you could think of it as a very toxic environment because these macrophages are sending out cytokines to propagate the immune response, right? So we have a lot of the inflammatory cytokine signaling going on. At the same time, macrophages are dying, and they're dying from apoptosis because they've sort of engorged themselves with these oxidized lipids that are very toxic to the macrophages themselves. So they die first by apoptosis, but then the rate of dying becomes, increased as the inflammation increases. And now we have necroptosis, which is a less benign form of dying, right? It's a pro-inflammatory way that cells die and signal to other cells that, they need more inflammation in that area. So we have just a lot of cell death and debris within the atheroma, and that debris is being gobbled up by surrounding viable macrophages, and also vascular smooth muscle cells. So they too are ingesting that debris. The lesion, as it grows, what we notice is that that rate of phagocytosis starts to be much slower than the pileup of the dead bodies, right? All the cell death that's going on. We just can't seem to gobble up and clean up as quickly because the rate of the cells dying is a lot faster. And so we have defective efferocytosis, which is the clearing of debris from a huge inflammatory response. And also with inflammation, we talked about this before, we have angiogenesis going on. However, the blood vessels that are formed in this environment, this very toxic environment, they're not normal blood vessels. They tend to be very fragile, and they're more like little capillaries. They're kind of leaky. They're very inclined to bleed. And so when you have leaky or a ruptured intraplaque vessel, then you're going to have intraplaque hemorrhage, right? And that's a big problem. So what happens with the calcification? Well, as I said, we have debris right in the center of that necrotic core, and that becomes a nucleation site for calcium phosphate, right? Crystals of calcium phosphate will now tend to clump around those apoptotic bodies. In addition, we have matrix vesicles that also can act as nucleation sites for calcium phosphate. Now, I wanted to do a whole episode on extracellular vesicles, but I didn't think, people would be interested. They're quite fascinating because these extracellular vesicles are really, in the end, membrane-enclosed particles that are secreted by different cells in the body. And we have a whole range of them and different ways to classify them depending on the size and the tissue of origin, right? Which cells are secreting it, the way they're formed. So in the category of extracellular vesicles, we have microvesicles, we have matrix vesicles, we have multivesicular bodies, ectosomes, exosomes, apoptotic bodies, etc., right? So just by looking at extracellular vesicles, there's a lot of classification going on. Now, what's interesting is the cargo that's contained within them. They tend to contain soluble proteins, lipids, and also non-coding RNAs. So what they do is that these particles transfer functional transcripts and also lipids to other cells. And this will change the recipient cell's phenotype. Very fascinating here. They can act locally, or actually they can impact cells in a distant organ or distant tissue, right? They can travel in the bloodstream, for example, and get to an organ somewhere else and act upon the cells there. Very interesting. Now, whenever you study extracellular vesicles or you read any article on them, you'll find that scientists who are involved in researching them, one of their biggest issues is separating them from lipoproteins, because lipoproteins are also membrane-bound particles, right? And they carry cargo as well. So in the field of extracellular vesicles, or what we call EVs, a big issue is, now how do you know that's not a lipoprotein and so forth, right? I found that really interesting because you could actually think of lipoproteins themselves as EVs or extracellular vesicles, I suppose. All right, so these EVs are found in calcified plaques in humans, right? And they are secreted by the vascular smooth muscle cells, macrophages, and stromal cells in the vessel walls. Now, with regards to the smooth muscle cells, right, their EVs actually contain matrix GLA protein and fituin A, and these are known to inhibit calcification, right? These are substances that will prevent calcification. But under pathological conditions, those vascular smooth muscle cells, they start to try to export calcium from the cell, right? Just remove calcium from within the cell to avoid an accumulation in the cell, because the calcium can be very toxic. And eventually we get to a point where there is imbalance between the inhibition of calcification and the calcium load, right? So we actually get to a point where we don't have much of the fituin A, we're depleted of matrix GLA protein, but we still have a very heavy calcium load. And those EVs themselves become calcified extracellular vesicles, right? And that's when generally we start to see calcification accelerate. So there are many, many factors involved in vascular calcification. And basically, you're making bone within the blood vessels. So you might as well just, look at the processes of bone formation, right? All the different factors that are involved, the signaling pathways and so forth, quite complex, right? And that's actually happening within the vessel wall. But I just wanted to point out that now we know that there is also secretion of these EVs, or extracellular vesicles, from different cells, the vascular smooth muscle cells and the macrophages in particular, that actually really initiate and promote bone formation within the blood vessels. Okay, let's move on to looking at risk factors, and there are obvious ones like diabetes and smoking. I'm not going to go into those. There are really two risk factors that I want to point out in today's episode. One of them being Lp(a). And this is a variant of, the LDL lipoprotein. It's positively correlated with calcification in arteries and also in valves, right, heart valves. And when we look at plaques and arteries, and we see calcified plaques and arteries, there's also a high volume of Lp(a) in the plaques. So, there's definitely a link between Lp(a) and vascular calcification. Now, that little a actually comes from apolipoprotein a, and that's why this lipoprotein is called Lp(a). And basically, the apolipoprotein a is a homologue of plasminogen. So plasminogen is something your body produces. It's something we call a zymogen, sort of a precursor enzyme, right? And when it is acted upon, it is converted to plasmin. And another name for plasmin is fibrinolysin. And this kind of tells you what it does. Basically, it breaks down clots. It lyses clots. So we have plasminogen being converted to plasmin, and then that plasmin can act on the clot and break it down. Well, because the apolipoprotein a is a homologue of plasminogen, it kind of competitively binds, right, to the plasminogen binding site. And so we don't allow plasminogen to act. The plasminogen that is in the apolipoprotein a actually is not able to convert the plasminogen to plasmin. So as a result, when we have Lp(a) around, we have less plasmin and less ability to break up clots, right? The other thing that Lp(a) does is it stimulates plasminogen activator inhibitor, PAI1. And this also has the net effect of really preventing plasmin formation and inhibiting the lysis of clots. But it's not just this that helps increase the risk for calcification. The LP little a actually has this tendency to carry around oxidized phospholipids. And it also carries an enzyme called autotaxin, autotaxin. And basically, we have lysophosphatidylcholine, and this is converted by autotaxin to lysophosphatidic acid. And this is a very, very pro-inflammatory substance, right? So the oxidized phospholipids can be converted to lysophosphatidic acid by the enzyme autotaxin. And so you imagine this LP little a has a lot of oxidized phospholipids on it, and it has the autotaxin. And now we're making a lot of this lysophosphatidic acid, which is highly, highly, highly inflammatory. So it worsens the inflammation around the atheroma. So that's why we think that LP little a increases your risk of cardiovascular disease and also of calcification in arteries and in heart valves, for instance. All right, so the other risk factor that I want to point out that will increase vascular calcification would be statins. So this is a little complicated because generally people are put on statins because we want to presumably lower their risk of having a major acute coronary event, right? We don't want them to have a heart attack. And there's this idea that if we lower the cholesterol, then we're going to lower the risk. And I already talked about cholesterol in an earlier episode related to atherosclerosis, and we looked at cholesterol metabolism and how immunometabolism is really important in this process, but it really isn't, in a sense, the prime initiator of the process. All right. So the point is that people are put on statins because this is supposed to reduce your risk of heart disease. Okay, well and good. Now, one of the ways that we assess for how much risk you're at is to look at whether you have vascular calcification, the idea being that the more calcified your arteries and plaques are, then the higher your risk of disease, because now you have a lot of these plaques around that have a lot of inflammation associated with them, resulting in vascular calcification. The problem is when you put people on statins, this actually raises vascular calcification in your arteries. This is very well known. Earlier studies said, oh, we may actually reduce the calcification or that it doesn't make a difference. But now it has become abundantly clear that when you put someone on a statin, they are going to have increased vascular calcification. So, for example, I have been asked by people who tell me that their coronary artery calcium score is 0, but because they have, very high cholesterol, they were told that they should go on a statin. Otherwise, their, a CAC score would go up with time. And I said, well, when they put you on statins, it's definitely going up, right? And they're shocked, and some of their doctors are shocked. And I'm like, you can look it up, It's quite well known that when you put someone on statins, you are increasing vascular calcification in them. So how do we explain that, right? I mean, you're supposedly trying to decrease their risk, but now they're going to have more vascular calcification. And the explanation that has been thrown around is a rather interesting one. It says, well, the vascular calcification that comes from the use of statins is protective, and all other vascular calcifications are not, right? So the statins just know to calcify your vessels in such a way as to be protective. And in fact, there are different studies that show that actually it's the macrocalcifications that stabilize the plaque, all right? They help to keep the plaque stable and prevent it from rupture. And it's the microcalcifications that are the main problem. And guess what? Of course, the statins are associated with macrovascular calcification. And that is why they are protective. All right, so let's move along. We'll come back to this in a little bit. Let's look at vascular calcification again, and it's the risk for a major acute coronary event, also known as MACE, M-A-C-E, all in caps, right? And we know that when you have increased vascular calcification, you have increased MACE events happening. Your risk for MACE will be higher. That we know for sure. And as I said, then we threw this around, especially when statins came in the picture, and the decision was that it's the microcalcifications that cause problems. The macrocalcification is actually protective, and of course, the statins are involved in the macrocalcification. Now, we also know that generally calcification occurs with microcalcified spots or nodules. These are very hard to detect on CT, all right? You have to have calcification of a certain size before it can be detected. So a lot of these microcalcification lesions are probably not detected. So when someone has a score of 0, well, there might still be microcalcifications, but we just can't detect them. All right, having said that, we know that microcalcifications occur first, and then eventually, right, there's coalescing of the different calcified lesions, and then we have a bigger structure, what we call a macrocalcification. So a macrocalcification doesn't drop from the sky. It doesn't just appear, abracadabra in your blood vessels. It comes from microcalcifications, right? It's got to come from somewhere. So, I'm just going to leave that in your head for a minute. Again, lots of studies being thrown around. But this one I thought was interesting. It looked at superficial and multiple calcifications and ulceration, right, in the calcified spots. And it was felt that superficial and multiple calcifications and ulcerations were associated with intraplaque hemorrhage in carotid plaques. So this was looking at the carotid arteries. And in fact, the deep plaques, the deep calcifications in the plaques were not associated with hemorrhage. So the feeling is that when you have the presence of calcium, this causes a stiffness mismatch within the vessel, especially when the calcium is closer to the lumen, right, where the blood is flowing. And there we now have higher shear stress and higher mechanical loading, and this is going to damage local tissue, especially the neovessels, right, those fragile vessels that have just formed and that are somewhat leaky, and also the thin fibrous cap. The deeper calcified spots, they have little or no impact on plaque stress, and actually they may even be protective, because if they're very deep, they may actually be forming a barrier to the vasa vasorum. Remember that in association with the atheroma, we're going to have proliferative vasa vasorum, and we don't want that vasa vasorum to invade towards the intima of the blood vessel. So if you have these deep calcified lesions, they may act as a physical barrier to prevent these neovessels from the vasa vasorum infiltrating into the intima from the adventitia, and therefore prevent intraplaque hemorrhage. So they indeed, the deep ones, may have a protective function, but it's really the superficial ones and multiple calcifications with ulcerations that are at higher risk for intraplaque hemorrhage. So even though people threw around the microcalcifications being, the damaging ones and the macrocalcifications being the protective ones, really, I think what we're seeing is that when you have superficial lesions, multiple calcifications, and you have ulcerations, that's probably going to be the worst for intraplaque hemorrhage. Okay. I also want to bring up a study by Xian et al. This was published in Arteriosclerosis, Thrombosis, and Vascular Biology in 2021. And what they did was they really looked at statin effects on vascular calcification. So it was pravastatin versus placebo, and they used a mice model, basically ApoE deficient mice, which had, predilection towards formation of plaque. And they gave the pravastatin to the study group of mice for 20 weeks. And both groups, control and pravastatin group, had increase in vascular calcification because the mice used were a model for atherosclerosis after all. So there really wasn't a difference at 20 weeks between the control group and pravastatin group in terms of the increase in vascular calcification. Both groups had that. However, the pravastatin group had significantly more aortic microcalcification deposits, right? The microcalcifications that we said were actually the worst type of calcifications, and they would cause the intraplaque hemorrhage because the macrocalcifications are the protective ones. Well, I said the micro leads to the macro. So if you have macro calcification, it had to come from somewhere. But furthermore, pravastatin and other hydrophilic statins actually seem to show more of this micro calcification when compared to control. And also, they showed more vascular cells that stained positive for alkaline phosphatase activity. So this means there's more bone formation in the vascular muscle cells of the pravastatin group. In that same study, they noted a previous study that showed that when you gave the pravastatin for 35 weeks, there was much more increase in calcification. Those mice had increase in percentage of calcified plaques when compared to control. All right, so we had a vast increase in vascular calcification when they were given the statins for an extended period of time. So I think this is going to be bandied about quite a bit, and there's always every time I go somewhere and I bring up this idea of statins raising vascular calcification, I'll get the standard, but the calcification is stabilizing the plaque because it's a macro calcification, not a micro. And I'm like, where does the macro come from, number one? And also, we keep saying that it's really the increase in calcification volume, right, and density that is going to lead to more acute coronary events. So I don't think we can get around that one. It's a good try, though. I thought they were rather creative on that one. All right. So I hope you were well entertained by this episode and the continuing statin saga. I just pointed out the vascular calcification because I thought it would make my series on atherosclerosis more complete. And in the following episode, I will also mention calcification as part of the immune process. Okay? All right. So that was it for vascular calcification. Before I end, I just want to invite you to my live stream events. As usual, ask me questions, talk about, your metabolic health journey. Maybe you have comments for me. There's something you want me to address. And you can find the dates of those live stream events if you go to my website, vlmd.com, VYVYANELOHMD.com. And also, if you'd like to work with me to improve your metabolic health, then you can join me on tulaversity.com. That is www.tulaversity.com. I'll put that in the description as well. And one more thing, if you are a practitioner or a health coach who's really interested in learning about metabolic health, but you really want the deep stuff, you want to go beyond the superficial, and you really want to try and understand the processes that are involved and have a solid foundation in metabolic health, right? And learn to think about metabolic health in a deeper way, then also look up the courses that are available on tulaversity.com, and hopefully, I will see you on campus at Tulaversity campus. All right, I think I'm done on this episode with vascular calcification, and I'm looking forward to the next one because it's brings in a lot of favorite topics of mine. So let's wait for that. All right, in the meanwhile, signing out from VLMD Rounds, I'm Dr. Vivian Lowe, and I sing the body electric. Bye.